Senate Committee on Advice and Consent is called to order. Will the clerk please call the roll?
Chairman Nesbitt.
Here.
Senator Bumstead. Here. Senator McBroom. Here. Senator Hertel. Mr. Chair, you have 3 members present. There is a quorum.
Move to excuse absent members. Without objection, the motion carries. I will entertain a motion to adopt the committee minute meetings from February 18th and February 25th. Without objection, the minutes are adopted. Today we are holding our second hearing with the Director of Health and Human Services, Ms. Hertel. Thank you for coming back again. And we're more on time this week than we were last week, so that's a good thing. So, do you have any further, or do you want us just to dive into questions?
If you don't mind.
Yep, go ahead.
Great. Thank you for having me back so we can continue discussing my role in the Department of Health and Human Services. I just wanted to thank you, and I appreciate the questions that you all raised last week and that we were able to start talking about. It really gave me an opportunity to reflect on the past year in a way that I have not been able to take time to do as we move through this response to the COVID-19 pandemic and working toward just making the next best decision, not really having time to think back on what we could change or what we could improve. And one of the questions was specifically, what do you think you could improve? And I'll say, looking back and thinking over the past year, I think one of the mistakes that we made was not communicating more effectively internally with each other, which I think could have prevented some of the things that you raised last week, like the contact tracing contract. And then communicating externally, both with the legislature and other stakeholders on policies and how we could implement those. And so I am grateful for the opportunity to have had that time to reflect and think about how to incorporate those changes within the department and in my role moving forward. And the other item I wanted to address that I've had a lot of time to think about since I was appointed to this position and over the last few weeks are the responsibility that the director has as it pertains to epidemic orders. Now, I understand that this is an enormous responsibility to try to balance the safety and health of the residents of the state of Michigan with the livelihood of the residents of the state of Michigan. That's a tall task that I do not take lightly, and I believe moving forward with this responsibility, both as it pertains to the COVID response and any other crisis that we might face, it's really important for me in making those decisions to ensure that I am getting as much information, suggestions, and feedback as possible in trying to make the next best right decision for the residents of the state of Michigan. And so I just wanted to thank you for asking questions that are difficult, and I hope that as we move forward, you continue to feel comfortable asking questions that are difficult and challenging me to think about the role that I have and the programs and services that the department has and how we work together moving forward to continue to protect the health and safety of the residents of the state of Michigan. So thank you.
Thanks, Madam Director. For coming before us, Senator Annick.
Thank you, Mr. Chairman, and thank you, Madam Director. And you've mentioned it, so I'm going to, you talked about difficult questions, so I'm going to offer a few, just because I think it's important to know. So I'm going to ask, what, if any, was your involvement with the termination and/or separation agreement with Director Gordon?
I didn't have any involvement.
Okay. Is it a possibility that the governor and the director had a difference of opinion on the reopening of our economy, the engagement with schools, and other engagements? And I'd like, yes or no, if you can.
Yes, it's possible.
Well, and to get a little more clarity on that, well, since you've been director, have we moved, as a state and the department orders, have they moved more towards reopening? Have they stayed the same, or have they become more restrictive?
We continue to be less restrictive with the orders moving forward.
Thank you very much. And then one last question. And you may be able to, I apologize if I get the name wrong, but I saw a story in the paper and I just wanted to make sure I addressed it. Lastly, can you speak to the separation of, I believe, Sarah Esty? And that will be my last question, Mr. Chairman.
Sure, thank you. When I was appointed director, one of the things that I wanted to be able to do was some reorganization with my team centrally in the administration. Part of that involved combining some different bureaus and divisions, sorry for the technical terms, to create a new administration. And in creating that new administration, I notified Sarah that her position would be abolished. And I let her know that if she was interested in having further discussions on, an agreement or how she would transition out, that she could speak to Human Resources, which she did. And ended up negotiating a settlement agreement. It did include some administrative pay, which I approved because she was an unclassified employee, not a civil service employee. She did not accrue vacation the same way that civil service employees do. So if she had been a civil service employee leaving, separating from state service, she would have been paid out any unused vacation time. And so I thought that that was a fair term for that settlement. And I approved it, and we are working to move forward with that reorganization and hiring a position for that. Mm-hmm.
I won't hold you to the only question, so thank you, Senator Ananick. I know a lot of committees do, and thank you. As we know, Department of Health and Human Services is a huge department. A lot of questions that we have, and so I'm just going to start off and then try to get through as many as possible and in the time that we have. So I guess off Senator Ananick's point, so did you authorize the $155,000 payment to former Director Gordon?
I did not.
Who did?
That settlement was worked out between the governor's office, I believe, and the director. I don't know. I was not involved.
You know where the money is coming from?
The money will come from the Department of Health and Human Services.
So why were you not involved?
I don't know.
Is the governor's office running DHHS?
The governor's office is not running DHHS.
Well, I mean, just kind of based off from this example, the governor's office handles human resources, special spending items, and restricting transparency involving DHHS. Do you agree with the $155,000 payment to Director Gordon?
I did not have anything to do with negotiating that settlement, so it wasn't up to me.
So you have no opinion on whether it was appropriate or not? Do you think it was appropriate?
I don't have an opinion on that.
Do you have autonomy to negotiate with the legislature on your budget?
I work in conjunction with the state budget office as we move through our appropriations process.
You make a commitment on a budget item with the legislature. Can you hold to that commitment?
Yes, Yes, I think we could hold to that commitment. But again, we work very closely with the state budget office, and so we are always working toward ensuring that the priorities both of the legislature and the administration are incorporated into those budgets.
So you don't have full autonomy?
I think it depends on what it is, but I believe that anything that we are negotiating has been put forward in the executive recommendation, and so we work to incorporate those recommendations as we go through those negotiations.
Do you believe COVID-positive patients should be placed in nursing homes with non-COVID patients?
I think the way that we are addressing the placement of individuals who have COVID-19 is really important to ensure the safety of the other residents in any facility, nursing home or otherwise, as well as the staff that are working with them. And so we continue to implement and work with the nursing homes and facilities to implement effective infectious disease control policies to ensure the safety of all residents and staff.
So what would be the criteria that you'd put COVID-positive patients into nursing homes?
We wouldn't develop that criteria specifically. We would rely a lot on the admitting facility to make the determination of whether or not they can safely care for those patients.
Did the administration make any errors regarding the nursing home policies which you could learn from?
I think continuing to move forward, getting input from the stakeholders who are implementing those policies is really important to understand how they're implemented.
Yes, do you believe that there should be further investigations into COVID-19 case and death reporting that occurred in Michigan nursing homes and other congregate care facilities?
I am certainly willing to continue to discuss with you or whoever is asking about how we have been collecting that data and reporting that data.
Do you think those numbers are accurate?
I do.
So you don't see the same issues that we see in New York is happening here in Michigan in terms of honest and truthful reporting of the numbers?
The reporting requirements to the facilities were that we were reporting nursing home resident deaths as either occurring within the facility where the person resided, or if the individual had been transferred to another facility, an inpatient setting, for services, that they would also be reported as a nursing home death.
Familiar with the report from CHART, the Center for Health and Research Transformation at the University of Michigan, on Michigan's nursing home policy?
Not intimately.
What?
No, not intimately.
But you know of it?
I do know of it, yes.
But you're not, have you read it or have you?
I read it when it came out, which I believe was about 6 months ago.
September, first week of
Okay.
September or so, beginning of, are you aware of any employees at the department or within the administration who met with CHART before the report was issued?
I was not involved in the development of the report, no.
Did you meet with them?
I did not.
Before issuing the report, did anyone at CHART provide any input or advice to the department about the state's nursing home policy?
I don't know. I was not involved in developing that policy.
So are you confident that the CHART report was actually independent, as the department has stated?
I've worked with CHART for a long time, and I think that they take their role in being an independent evaluator very seriously. So yes, I do think it was independent.
What were the roles that you worked with CHART in the past for?
I have gone through the CHART fellowship, and I have used their research and analyses for policy development in other areas.
Dealing with schools and education, virtually every technical medical expert for quite some time it says kids should be back in school and can be educated safely. Do you agree?
I'm sorry, could you?
Do you agree that kids should be back in school and that they can be educated safely?
I think what we, with the guidance that we've gotten from the CDC and other health experts, that children can be safely back in school. I do think it's important to ensure that our local districts are able to make that transition from virtual to in-person in a way that is safe and protects children's health.
Are there exceptions?
I don't know.
Have there been any mistakes with the administration's orders related to schools?
I have not been involved in the orders related to schools.
No, none of the orders related to schools.
Aside from the athletics.
There has been some rather dramatic examples of the negative effects of keeping kids isolated and out of schools. Some of these examples are sadly the ultimate and regrettable outcomes. What liability do you think the department has in causing these losses?
You know, as a parent of 4 children who had been virtual schooled for a year, I am very aware of the effects that had on their mental health. And we were lucky that we didn't have some of those very dire outcomes in our own family. I think that in order to move forward, we continue to strive to make sure that kids can have an in-person option. And we continue to ensure that we are providing resources to both parents and children and families together to help address some of the mental health effects that may have been experienced throughout the pandemic.
Yes, will you commit to not closing schools or shutting down sports again?
I think that if we continue to see the numbers trending in such a positive direction, that we won't need to have that conversation.
So you're not willing to make that commitment?
It's hard to make a commitment based on a virus that we are still learning about and unsure of how aggressive it will be and what we will see as far as transmission. But I think if we get to that point, that's a discussion that we all should have to ensure that we are keeping people healthy and safe, while also continuing to try to balance the mental health and well-being of our students.
The CDC reports that I've read and seen show that it's safer to actually be in schools than just being out in the community in terms of the spread that's there. Am I right in that?
I haven't read those reports.
Okay. I guess real quick in terms of these first sets, did Dr. Khaldun, along with the state epidemiologist, Dr. Sarah Lyon-Callow, provide you specific recommendations for your orders restarting high school sports, keeping restaurants at 25% capacity until the end of March, and then reverse that decision to expand restaurant capacities to 50%?
No.
So the state epidemiologist and the chief medical officer for the state didn't provide you recommendations for these orders?
Oh, I'm sorry, I meant no to the reverse. Yes, I work very closely with Dr. Khaldun and Dr. Lyon-Callow on looking at the data and the trends that we're considering and getting recommendations on how we should continue to lessen restrictions, while also trying to ensure that we aren't causing any spikes or significant outbreaks of COVID.
Can we see the recommendations and their explanation of the science and data behind that decision?
Yeah, that's a good question. So I've been working the past few weeks to be able to put together an explanation that demonstrates what we've seen since we started addressing, since the response, since we became aware of COVID and started addressing this response, to show everything that we've learned and the data that we've been able to collect over the past year in the state of Michigan, around the country and around the world, to show what we see when we see spikes going up and then when we see loosening of restrictions and how that affects the curve, so to speak, of our case rates. So yes, I'm looking forward to having further discussions, hopefully, on what that is and what we look at.
I mean, sort of on the joint COVID committee last year, I think we had dozens and dozens of folks that testified, including them, Dr. Khaldun and Dr. Lyon-Callow, and they both testified that they never provided the governor with specific recommendations when she was issuing orders. So now the doctors are providing specific guidance to you, but they never did that to the governor before?
I was not involved in the discussions previously under the orders.
But they're providing you specific recommendations on saying that they jointly saying that we believe that restaurant capacity should be at 25%. They send you a recommendation that we believe that sports is safe to play in a school setting.
We have discussions about the risk level of each of these environments, and given where we are with the case rate trends and the other metrics that we look at and consider, we have a discussion and we come to a recommendation together on what we think would be appropriate, and then I take that final recommendation. I've been able, over the last couple of weeks, had the opportunity to speak to others about some of their input on what they think that should or could look like, how we could potentially implement that, and coming to a decision.
In your testimony last week, you were unable to provide any specific matrix for the decisions, and yet another set of orders were issued this week.
Yes.
How specifically did you arrive at these changes and these new orders this week?
What we've seen in the state of Michigan over the 6 weeks prior to this one was a significant decrease in our case rates and our positivity rates, which means we are heading in the right direction. and people are continuing to take mitigation measures seriously. So we continue to loosen restrictions that under the epidemic orders, to re-engage in some of those activities in ways that we hadn't before. Once we loosen those restrictions, what I expect to see over the course of the next couple weeks will be an increase again in the case rates, and then hopefully we will see that either level out or decrease again.
What is the I guess why is the capacity that these rulings that you have is not based on square footage, such as the number of people per 1,000 square feet?
So the risk level of transmission increases as you put more people in a room together, intermingling outside of an individual household. So being able to minimize contact between multiple households or multiple bubbles, if you will, is important in continuing to mitigate transmission.
So why, I'm just kind of confused on why is it just a sheer set of number of people instead of like a square footage where, again, I get it, it's, when you're close, confined spaces, that's what you want to provide, or close, confined spaces. So it seems like a larger room would prevent people from being close and confined, and so it would naturally allow for more people to be there.
It depends on the setting, which is why we have a difference between fixed seating and non-fixed seating. So if you're in a fixed seating environment like this, where people are seated, they're not intermingling with each other, there's going to be less risk than if you're in, say, a large banquet hall, where people are moving around and greeting each other and possibly hugging each other, or that sort of intermingling. So that's the difference, is how much are people interacting with each other or with somebody outside of their typical household.
So talking about the specific homes and trying to, I get the goals, if you're from the same household, have at it. If you're from multiple households, then, look at it as there's some risk involved in what's there. But what data show, so I'm from a family of 7. I have 2 parents, 5 kids. I'm just kind of wondering what data shows that a family of 6 in the same household can sit together at a restaurant at the same table when dining, but not a family of 7.
Yeah, that's a good question that was actually raised to me this week. And it was one of those things that hadn't been brought to my attention previously, and so we're working on putting together an exception to allow for that to happen. Because you're right, if those 7 people are together in a household normally, there's no reason they shouldn't be able to have dinner together in a restaurant.
Or the senator from the UP having, 13 in the family or something.
And the key
That'd be really expensive to take them out to eat, though. Yeah.
And the key on that is the single household. That's the important part.
I guess that's kind of the challenge is I look at other, whether countries or other, states or locations, that why don't we decide to do the challenge of saying, if you're from, no more than folks from 2 households, and try to limit seeing I guess challenge folks to do the right things instead of mandating a one-size-fit-all type of policy.
It's difficult, you're absolutely right, to try to do a one-size-fits-all policy. And that's why I think it's really important that we continue to have these open discussions as we talk about loosening these restrictions, so that we can find that balance between ensuring people are staying healthy and saving lives, but also ensuring that what we're putting in place is something that can be implemented in a simple way.
I guess with the orders, there's a different percentage for pool capacity from different percentage, it's not even a percentage capacity on ballroom capacity, but then it's a certain percentage capacity on restaurant, if they happen to have food. I guess, can you walk me through on how, I think a pool is like 30%, and then a restaurant's like 25% capacity. I mean, walk me through how these numbers are different like that.
So again, what we're looking at in each of those individual environments is the level of risk and how large the space is, what the ventilation looks like, how much people may be potentially intermingling or staying with their the group, their single household, and working to loosen those restrictions up slowly so that we don't cause a spike or a big increase in case rates, while still continuing to be able to allow people to engage in those activities.
I had a hotel owner contact me and recently, and he shared the example. It's like, I can put more people in my pool than I can put in my 10,000 square foot ballroom. And he's been dealing with crying brides, and he's been seeing the business go to Toledo and Indianapolis. I mean, I live 45 minutes away from the Indiana border. I guess, what do you have to say, to these business owners and also folks that are wanting to get married or have their life events in Michigan, and they're having to go 40 minutes south of me to Indiana or 40 minutes south of Monroe to have these have these events?
I think that as we continue to look forward, we are seeing those positive trends, and that's really heartening. It makes me feel optimistic to be able to continue to re-engage. The other things that we are seeing are that we have tools now that we didn't have previously, where we can work to ensure that we're maintaining the health and minimizing the risk of individuals who are engaging in those activities, like the increased access to testing and vaccines. And so over the course of the next few weeks or few months, until we reach the end of where we are here in this pandemic, that we continue to have these discussions and work on these things and work with these business owners to make sure that we are allowing people to have those experiences that they want to be having in a way that, again, minimizes the risk of COVID transmission.
And again, this is something where, again, maybe it's anecdotally, maybe there'll be some study sometime on it, but in January, going through Elkhart or South Bend or Middlebury, along the border of Indiana and Michigan, 90% of the plates there were Michigan license plates. 2-3 hour waits for restaurants there. And I think that's just something where there's consequences to all these decisions, and whether it's lost business and how's that preventing people from actually gathering. Instead, they're just going to another state. Does that factor in at all to any of these decisions?
Yeah, as I mentioned in the beginning, one of the most difficult challenges is being able to balance the health of the people, of residents of Michigan, and the livelihood of the residents of the people of the state of Michigan. And I will continue to work toward making sure that we continue to save lives, but in re-engaging in a way that is positive and safe for all of those involved, both business owners and residents.
Senator McBroom.
Thank you, Mr. Chairman. Thank you, Director. I guess I'd probably just like to start where the chairman left off with discussing the issues of regional planning. I left you with that at the end of last week's questioning as well. And for those of us on the border in particular, I think, and I'll let Senator Bumstead comment for those in the middle of the state, I guess, but for those of us by the border, it's particularly profound to see people who can just basically get around the orders that we put in place and go somewhere else and really negate the benefit that's supposed to come from following the orders, in a sense. And it's certainly really impactful on the businesses. If you're not going to wait for businesses to be open before you take your money, or if you're not going to wait in line before 25% capacity is fallen below so you can get a table, and you just go across the border, or they're taking their money somewhere else and then coming back with whatever problem they may catch there if it's there. So I guess I'd like you to comment more on why you oppose a regional approach in light of those realities that we see on the ground.
I did not mean to give the impression that I oppose a regional approach. I don't. I think what we're seeing right now are the case rates across the state that are fairly similar. And so we're able to do things, lessen these restrictions on a statewide basis. If we see spikes in a certain area, and we did, specifically with the first time the B117 variant was identified in Washtenaw County, we were able to work very closely with the university and with the county to put some further restrictions on that area to minimize transmission of that variant, and that was very useful. So I think there is certainly appropriate time to do things regionally, and then there are times to do things at a state level, and we just have to continue to make those best decisions as we come across them.
Thank you. Could you elaborate then on how we determine when it's right to do that? Because I mean, the governor put together a panel of experts to create a regional plan that got announced, then it floundered, and then it sort of got implemented, but I never really felt like it was truly being followed, and immediately it started kind of getting carved up and not really being followed with any strictness. So I guess how are we deciding when we use it and when we don't?
We saw the case rates after that that regional approach was published. I only know it by the acronym MERC, the MERC regions. So we saw, I think there were 8 or 9 of them. And I know the state began to implement things differently regionally. And then we saw the case rates increase across the state. And they were all reaching that high risk level. Many of the regions continue to remain in what would be that high risk level now. But I think that's why this is a good time for us to take a look back at what we've seen over the past year and looking forward to see if it's appropriate and how it's appropriate to potentially re-engage differently from different regions, and taking a look at the numbers previously that had been established to see if they continue to make sense. And so I'd like to spend the next, again, few weeks or months working internally with my team and externally with you and other stakeholders, and helping to put that sort of plan in place.
How is it that the administration, the experts in your department, other departments, how do you go about analyzing the outcomes of the actions that we take? How do we validate, vindicate, critique, or even pan decisions and orders that have gone by to say that didn't work or that does work? And what's the process that's happening, and what role do you play in that process?
We are able to now look back at the metrics that we've been focusing on for the last year, and not just in the state of Michigan, but most places have been focusing on, which is that case rate, that positivity, the hospitalizations and death. And we can actually map, and I would like to be able to, this is one thing that I do want to have a further discussion with you on, all of you. We can map and see how the interventions potentially affected what those case rates and hospitalizations are. And we can compare that to different regions, whether those are states or countries, and the mitigation measures that they put in place at the same time. I think it will probably, from a research perspective, take more time to scientifically validate any sort of causation or correlation between those. But what we saw was overall, everywhere, when we were able to have people wearing masks, continue to social distance, and not be interacting with members of, or with people outside of their households, that we would continue to see those case rates go down. And so I think this is a good time to be able to take a look at that as we re-engage where we are with these additional tools and the things that we have in place now that we didn't have 3 months, 6 months, or a year ago, and the amount of knowledge that we have regarding this virus, which we didn't have a year ago, to be able to put together a plan and be thoughtful about what we're going to do moving forward.
Can you give any specifics of look-backs that have occurred that, you know, everybody in the administration says, yeah, that didn't do anything, that was unhelpful?
Nothing specific that was unhelpful from what I've been looking at of the orders. But I can to put a couple of examples of things that were helpful. After there was the discussion.
And I was going to ask you for that too, so I don't want you to think I'm
Oh.
being fair here. I was going to ask you that after that, but go ahead.
There was the legislation on creating the CRCs for the nursing homes, and those were put into place. In November, we started implementing them, and that's when we started seeing a really steep spike in case rates across the state. Hospitals were starting to feel pressure again because they didn't have a lot of room, and we were able to implement that CRC and work with the nursing homes and the hospitals to be able to safely discharge patients into another safe environment based on that policy. So we saw that lessen the pressure on hospitals, and that was really helpful. I think on the other perspective, you know, if we look back over that case rate graph, I think we would have maybe been a little more concerned earlier in the fall about the increase in the case rates, and potentially tried to put some more restrictions in place that wouldn't have resulted in a steep rise. But we can see those sorts of things now, looking back on the data that we were able to collect.
So I guess, and I'm going to, you know, this is always challenging, I think, to some degree, because you're in the thick of it, you're in the department, you have more tactile information than we necessarily have. We have more of the observation, you know, type materials. So I need to speak to you as my constituents speak to me about what they're experiencing, what they observe. And so you look back on last April, March, and May, and you see very broad orders that resulted in, you know, retail restrictions, restrictions on travel, restrictions on, you know, boats. I mean, there was a lot of things out there. And then we go into the fall when we have what you call the second wave, or for those of us in the UP, kind of our first wave. The same policies were not implemented. There were some that were re-implemented, restrictions on restaurants, clearly, and venues, and people gathered together, but other things didn't come back. And I think my citizens want to know why, what was the difference? What was found that said, you know what, we don't need to restrict motors on boats, we don't need to restrict access to certain retail activities, but we still need to do these other ones. And I think my citizens on top of that want to know if there's another spike, if the numbers go bad again, how do we know what things will come the next time around and what things won't?
That's a perfectly reasonable question to say what will come and what won't. And I appreciate that. I wish I could give you a definitive answer on the difference between the orders that were issued in the spring and the orders that were issued in the fall. But again, I was not involved in the development of those, so I can't. But what I can say is, as we continue to move forward and move through this pandemic response, it's important to me that we continue to have those conversations so that we can continue to create policies that make sense as we are responding to COVID-19 throughout the course of, you know, the next few months, or, you know, the next year, hopefully not, but as long as we need to.
Thank you. There's been several answers to both the chairman and then to my questions, well, and even to Senator Ananich's questions earlier, where you mentioned, well, you weren't involved with something. I guess, Could you clarify again for me what your role was as a deputy and why you weren't involved in those decisions at that time?
Yeah, I was focused on, in my role, the operational functions of the department. Was not involved in general policy discussions, and that was true prior to COVID as well.
So there are 3 deputies, correct? And so do any of the deputies get involved in the policy deciding issues?
They do now.
Oh,
That's one of the things that I, upon reflection over the last year and thinking about moving forward in the department is ensuring that we have communication so that people are aware of what the concerns are, what the actions are that we're thinking about taking, and having those open conversations to get as many perspectives as possible. And again, that's important internally and externally.
last week in my questions, I asked you some about what considerations you make as a director at the department when you're doing health orders, epidemic orders, as far as their impact on economics. And as I thought more about your answer, I want to follow that up with, who within the department do you rely on who is an expert on economics? Who's analyzing the historic data that you mentioned, or just even the contemporary data that we have now about economic issues? I mean, you wouldn't necessarily think the health department is hiring an economics expert, but perhaps you have one. So could you elaborate on that?
We don't do that internally. We rely on Leo.
On Leo?
Yes. And they put together the economic analysis. And so if we see the health data perspective, and then we are also able to look at it from the data that is collected and analyzed by Leo on the economic side.
Okay, thank you. And then last question I have for the moment, Mr. Chairman. Could you give us your thoughts on giving more authority to local health departments as right now or at a certain point in the future regarding handling the continuation of the epidemic?
Local health departments have a significant amount of authority in handling, addressing outbreaks or epidemics. And we continue to work closely with them on this and other outbreaks as we see them. As I mentioned, we were able to do that with Washtenaw County Health Department as it pertained to the B117 variant. And so I think it's really important that we ensure that local health departments continue to have that authority and that we work closely with them to support them in, making changes or implementing policy that they think is necessary in their districts.
Is there a way for local health departments right now to funnel information high up the ladder in the department so you can hear what's going on at the local level from them?
Yes, we speak with the local health departments quite often, daily, in the different medical officers and directors. So we work to get as much information as we can from them about what they are seeing on the ground, both from a data perspective, also as we're rolling out vaccines, doing testing. We need and rely on that feedback from them because they are the ones who are actually implementing a lot of this.
Do you think that there's been have you been able to do anything in your tenure now that's working to improve those lines of communications? Because I got a lot of complaints over the last several months from health departments about their ability to communicate, to feel like they're being heard by the upper levels of DHHS. Is that something that you've noticed or that you've put any special attention into since you've been in your position?
So since I've been in this position, I do meet weekly with the Michigan Association of Local Public Health Departments. That I am able to join some of the calls, the regular daily calls that they have. But if there is a concern that we are not communicating enough or appropriately, then if you could let me know, because I think it's really important that we make sure that those lines of communication are open and candid. That's the only way that we're going to be able to continue making progress.
And one last note on this line of questioning. Seems to be a significant amount of confusion at various health departments as to what level of authority they have or don't have, and to the structure internally between their medical officer and the director. Seems to be significant tension in various departments over who's actually in charge and who gets to do what, and it's something that I'd be very interested in knowing if there's any guidance from the department to help a legislator know the playing field at their local health department, because I see, I represent 12 counties, so there's a lot of variation.
We certainly want to be there to provide the support and resources to the health departments in carrying out their duties, and to their constituents and being able to understand that. So as much as we can do, I would really welcome that.
Thank you. That's all for now, Mr. Chairman. Thank you.
Senator Bumstead.
Thank you, Mr. Chair. Good afternoon. Thanks for coming in. The first question is kind of two parts. Can you tell us about the science regarding why curfews have been implemented for Michigan restaurants, and what data is there to suggest 11 p.m. or 10 p.m. or 11 p.m. helps when fighting COVID?
That's a good question. We were looking at a number of other states to see how we were measuring up to some of the restrictions that they had in place as well. We had that original curfew of 10 o'clock. We moved it back to 11 o'clock because we want to ensure that we are minimizing, interaction between people in high-risk environments, and we know that restaurants are one of the higher risk environments, and so that's why we implemented the 11 o'clock curfew this time.
Did you look at that, probably not regionally, but more just a statewide average, the curfew? Because, like Senator McBroom and I in the rural areas, everybody's just wondering, why are we into that? And we get that question a lot, at least I do, up in my area.
Yeah, I looked nationwide, yeah.
Okay. And last week I had a meeting. I have only three counties. But I met with one group out of Oceana County. 4 superintendents are on the call, 2 Republicans, I believe 2 are probably Democrats or independents, whatever, that doesn't matter. And they've all been open basically September. They haven't, a couple of them have done 1 or 2 days full, 1 or 2 days virtual, one is 1 day virtual. They've done it their own way in doing their, I'm a firm believer in local control. That's why I like the regional approach to everything. It seems like they've got it figured out without the state telling them how to figure it out. And they've done a really good job. Their numbers are very low. Students are happy. Students are learning. The teachers seem to be all on board with the different structures they put in. And I look at that as, why can't we do that with, why aren't we looking at businesses the same way? And I agree with Senator McBroom. I think we need to look at things more regionally than a southeast approach or whatever, where there are issues or problems. Let's address that, but everybody else, if they're doing right, the numbers are right, let them kind of do their own thing. And that's what I'm hearing a lot up in my area. So that's just my 2 cents worth on that. Couple questions regarding, and I know you're, yes, regional, yeah. The Lakeshore, I have Muskegon. The Lakeshore Regional Entity, which works with our local mental health service providers, has struggled financially over many years. How do you envision stabilizing that funding?
As you know, Senator, we've been working very closely with the Lakeshore Regional Entity over the last couple of years. We are currently still under legal discussions and settlement discussions with the LRE on that. But I think through the course of the past couple of years, we've seen a lot of positive changes from Lakeshore Regional Entity, their governance, their approach to their financial resources, and our ability to work closely with them on trying to implement a stable financial baseline so that they can appropriately continue to fund the services that are necessary. I think it's really important that we look at not just the Lakeshore Regional Entity, all the PIHPs statewide and the CMHs, and how we are funding them, what those funding levels look like, and ensuring that from the state level, we continue to provide oversight and accountability for those entities, and then support for them when they know that they may be coming into some sort of, hopefully not to a point where they're at a crisis, but when they may be experiencing difficulties, so that we don't have to continue or ever have to go through these discussions again like we did with Lakeshore.
So they never have to face that again.
Yeah.
Do you believe the current funding model is for the LREs and other regional entities is appropriate, or would you suggest changing that down the road?
We've been looking at that rate setting model for a couple of years now. And we continue to, as you know, every year look at those rates from an actuarial perspective to make sure that they are sustainable. I think that it's important in working with the PIHPs and the CMHs to understand the agreements that they have with each other, because we know the one flows to the other, and ensuring that their payment levels are appropriate. I think it's always a good opportunity to review how we're funding things and how those things are being appropriated down at the provider level to continue to have that accountability for those funds.
Thank you.
Thanks, Senator. Senator Amnick.
Thank you, Mr. Chairman. I'm going to piggyback off of a couple of the questions that my colleagues asked, and I'm sure the Restaurant Association just loves us talking about them every week, but, but I do want to ask a question about that. And you may not have the answer, but to your knowledge, have Michigan's restrictions on restaurants had a disproportionate impact, or more disproportionate impact than surrounding states? You may not know the answer to that.
I don't know the answer.
Well, on February 19th, WXYZ did a investigative report, and they suggested that Ohio had 4,000 restaurant closures, Michigan had 3,000. Indiana had 20% of their restaurants close, while Michigan had 17.6. That doesn't make any restaurant closing in any place. Someone's life work, obviously something they put their blood, sweat, and tears into, that doesn't make, because we happen to have less closures in another state in our region, that doesn't make it any easier, of course. But with neighboring states actually having more closures, do you see any need for long-term support for restaurants and lodging? And would you, if one was presented to you through the legislature, would you be supportive of that? I know you mentioned you work with Leo on economic data, but if you could opine on the potential for long-term support for restaurants while we weather this economic storm and get out of it, would that be something you'd be supportive of?
In the Department of Health and Human Services, we have a prime focus on the health and well-being of the residents of the state of Michigan, but we also spend a great deal of our time on the human services side, which is providing opportunity for people in the state of Michigan. And I don't think that the opportunity stops when it comes to just an individual or a household. I think opportunity for businesses and their employers, or excuse me, their employees, to continue to strive and thrive in this environment is important. And any way that the state can support that, we should be advocating for.
And then my last question, if you don't mind, Mr. Chairman. From a, I believe the chairman mentioned the mental and well-being of, you mentioned students, but I think it obviously on all residents. And this is a tough question, and I apologize. We've been dealing with it or grappling with it for a long time. I don't think very successfully, but so it's a tough question for you, but do you think the integration or potential integration of mental health and physical health would provide, especially in the times we're in, if we could find a way to finally reach a sensible way to do that? Do you think, one, does that make sense? Is it something we can feasibly do, and would that provide the kind of services, not just during a pandemic, but afterwards, that I think a lot of our citizens truly need? So I asked a bunch of questions there. I hope if I need to clarify, I will.
No,
but
I'm
not an expert in health policy by any means, but it's something that I know is something we've talked about for a long time, and I'm wondering if it's something you think we could achieve, and should we?
Integration of services is vital in being to address each person's health needs adequately in a holistic way. And the fact that we still talk about physical health and mental health as being separate, I think is an indicator that, clearly we still treat them separately, and they're not separate. They are the health of an individual, whether it is a result of a physical anomaly or whether you have a behavioral health diagnosis. And wherever you're going, you should have an access point to get services for either one of those things. And so working toward creating more opportunities and access points that support that is really important for both adolescents, but adults and younger children as well.
Director, just a point to piggyback off the senator from Genesee County. Just to note, year-over-year sales for restaurants in Michigan are down 57%, which is the worst in the nation. So just in terms of a National Restaurant Association survey of all 50 states, it's just a note. Going back in terms of I guess the relationship between the director and the deputies, whether including deputies on policy decisions is a new process that only started under you?
I'm sorry, what was the question?
Including deputies on policy decisions, is that a new process that only started under you then?
I think every leader creates the team that they want to have in specific areas, and I think that the previous director did that, and I will do that as well.
So that wasn't the case with the previous director?
I was not included in policy discussions.
You kind of brought up a little bit earlier, or I guess some of the other questions, you kind of mentioned in passing that there was a disagreement with the governor and Director Gordon. What was that disagreement?
I don't think I said that there was a disagreement between the governor and Director Gordon.
At the beginning, you meant, I thought there was a mention that he left under a disagreement with the governor, and I was just wondering what that disagreement was.
I wasn't involved in the director's resignation, so I don't know.
I'll have to go back and take a look at that. I thought there would. What would you describe as the interaction between the Department of Health and Human Services and the Michigan Public Health Institute?
The Michigan Public Health Institute was an organization that was created through statute 23 years ago or so to create an organization that could provide support to the state in bringing together academic research capabilities to support the policy development and implementation of things happening at the state. So we have that relationship through statute with MPHI, and then we in the department have seats on that board of the organization.
Do you believe that it's appropriate for you to serve as both the director of DHHS and president of the MPHI board, considering the significant amount of latitude the department has to direct work at MPHI?
As the board chair of MPHI, I'm not involved in the day-to-day business decisions that that organization makes, but I have the opportunity to provide input on their strategic vision and where they want to go moving forward.
And you're still going to serve as as chairperson of the board of directors at MPHI?
I am the board chair, yes.
And you plan to continue to serve as board chair?
Yes.
What's the budget of MPHI?
I don't know offhand.
Do you know where their biggest source of funding is?
The state of Michigan is a significant source of funding for MPHI, but I don't know what their biggest source is.
Do you know what % the state makes up of their overall budget, or?
I don't offhand. I would have to look back through our financials.
Did the administration make a mistake by circumventing the normal process to give a Democrat political firm a no-bid contact tracing contract?
The process that went into the identification and final execution of that contract was a process that we don't normally utilize. Again, this was one of those areas that I think had there been more communication occurring internally, that there could have been some guidance provided on the state's expectations for how we contract and what we're looking for when we do contract.
Were you involved in selecting the firm for the contract?
I wasn't.
The governor's office is highly involved with the communications director of all people giving direction on which entity named the vendor should use for the contract. As you say, you were one of the 3 number 2s at DHHS and the board president of the Michigan Public Health Institute, or board chairperson of the Michigan Public Health Institute, yet the governor's office was more involved than you were.
Well, as the board chair, again, I don't have, I'm not involved in the day-to-day business dealings of MPHI. As the chief deputy for administration overseeing financial operations, I absolutely should have been involved in the discussion about that contracting, and I was not.
Guess what changes did you make at MPHI to prevent the governor's communication team from meddling in contracts?
I don't think we put anything new in place at MPHI. Again, we refocused internally at the Department of Health and Human Services, where that contract originated from, to ensure that people understood and were following the policies and procedures that we have for contracting.
Were they followed at the time?
On the that contract that was,
Yes.
I wasn't involved in the development of it, so I don't know how it came about actually, but I would have preferred to have more oversight of that process so that I could have ensured that they were.
Even with the media firestorm that was created last spring, there was no review on the processes that were made?
We did do a review following that, yes.
And corrective action has been taken or not?
Yes.
Now, I guess at the outset of the pandemic, about a year ago, and for many months, the governor and administration routinely highlighted the lack of personal protective equipment and testing supplies. For example, on April 6th, Governor Whitmer said, quote, "We don't have enough PPE." And on May 12th, the state chief operating officer said, quote, "Whether it's testing supplies, whether it's swabs, or whether it's capacity, there's a shortage." Was the Department of Health and Human Services fully utilizing Michigan resources, including the private sector, to solve this problem?
The Department of Health and Human Services was working closely with DTMB, who, as you know, is our state purchaser, to ensure that they were able to identify the appropriate types of supplies that we were looking for. We were not working directly with vendors at the Department of Health and Human Services.
I heard from many PPE suppliers that they tried to offer these critical supplies at a fair price and were totally ignored by the state. Couldn't get return emails, return calls. For example, a Michigan manufacturer, in conjunction with Harvard, developed a testing swab that was approved by the FDA, made right here in Michigan. His firm was selling large quantities of these Michigan-made swabs to other states and entities within Michigan, yet it was ignored by your department. Why do you think that was?
I'm not familiar with who that was or what the type of swab that they had to offer was, but again, we were looking to acquire as many of the appropriate supplies as possible, but DHHS was not working directly with vendors.
This April 22nd Detroit News, article. I'll give it to you. I mean, it goes into a manufacturer that does 3D printing and does it for Harvard, Minnesota, other places, trying to knock down the door here in Michigan. Couldn't get any answers. Bob Wheaton, a spokesman for the Department of Health and Human Services, said Michigan follows a careful process for vetting medical supplies before making purchases, particularly when new technology involved. Because, quote, "Because 3D printing swabs are new technology, MDHHS is undergoing due diligence to ensure every possible product meets all the best safety and accuracy standards for the people of Michigan. The department appreciates the work that they do." FDA approved, so you guys have to do another layer besides FDA approval?
Our labs and the labs that we work with do their own testing of supplies to ensure that those supplies that they're receiving or purchasing are appropriate and useful.
So FDA approval isn't a good enough seal for what
FDA
they're...
approval is the first step. in that process, and then we rely on our experts in our lab and other labs to make a determination on how useful and usable many of these supplies are.
The firm worked through Senator Peters and Congresswoman Dingell to try to get in touch with the Whitmer administration, DHHS specifically, in late April because the CEO was so frustrated about the state of Michigan ignoring these crucial testing supplies. The story that I referenced became public. And as I mentioned, DHHS was quoted in the media stories, yet when the CEO testified before the legislature in July, I believe it was the middle of July of last year, his firm had still not heard a word from the state of Michigan. Why do you think this Michigan manufacturer was ignored? And by the way, we heard the same story from Michigan PPE suppliers.
I don't know the specifics of this incident, so I couldn't speak directly to that, but I know that DTMB and SEOC were working with multiple vendors trying to obtain the supplies that were necessary for the state.
Do you believe mistakes were made involving DHHS ignoring the private sector?
How do you mean?
Manufacturer right here in Michigan, or at the time throughout the spring, we kept saying these extension after extension after extension of orders were being created and made because we didn't have enough testing supplies. We didn't know who was infected and who wasn't infected. We have a manufacturer that right here in Michigan producing millions of swabs that could be used for testing. And I'm just wondering, companies like this that came up to the department saying, we can help with these resources to reopen the state, re-energize our economy, get Michigan back going by knowing who has the virus and who doesn't have the virus. Do you think mistakes were made by DHHS to ignore the private sector and the ability that they have?
I am by no means an expert on the types of supplies or swabs that are necessary to do accurate testing or the actual tests on those samples that are collected. However, I think that we did work closely, not just DHHS, but the state as a whole, with many partners in the private sector to ensure that we were obtaining the supplies that we could get at the state level. And we continue to do that now as we work to ensure that we have some sort of stockpile in place so that we don't run into that issue again.
So will this change under your leadership in terms of, I guess, partnering, working with the private sector instead of shutting them out?
I think it's really important to make sure that we have all the stakeholders at the table so that we're putting together the best response possible for Michigan citizens.
I have a few questions on some of the, I guess, more on the rulemaking process, and this has happened over the last few years. Now that the federal government is, so a little change of course from pandemic. As we said, this is a big department.
It is.
Yeah, it's now that the federal government has implemented a purchase age of 21 for all tobacco products, including vaping products, do you have further legislative or rulemaking priorities regarding vaping products?
I understand that there are currently discussions occurring on legislation regarding preventing vaping products from being sold to children, and we would continue to encourage taking any steps forward in preventing children from vaping or starting smoking before the age of 21, and continuing to deter anybody from vaping or smoking.
Do you think the products that receive FDA pre-market tobacco products application approval should be allowed to remain on the market in Michigan?
I think we'll continue to follow the implementation of both the federal and state laws and work to ensure that people are aware of the risks that are associated with some of those products.
I have a lot of friends that smoke long time, since high school, college, you know, decades now. Tobacco, yeah. And they've been successfully able to get off that using vaping products, flavored vapes specifically. Do you think that banning flavored vaping products will actually stop people from acquiring them?
I don't think we're working to specifically ban vaping products. We're working to
Flavored vaping products.
implementing the federal law and trying to ensure that kids don't have access to those. But any individual who is, looking to quit smoking should work with their provider, their doctor, to figure out the best way to do that. We at the Department of Health and Human Services offer support and resources as well.
But that's not really the case. I mean, tried to ban all flavored products under the rulemaking process at DHHS. Am I not correct on that?
Under the emergency rules.
Yeah. And so you don't support those emergency rules that tried to ban?
I think we need to continue moving forward on how we want to prevent people from becoming addicted to nicotine and tobacco either through vaping or smoking. And we should continue to work together to find ways to do that.
Do you think if you ban them here in Michigan, that people just go online and purchase them?
I don't know.
You think if you ban them here in Michigan, that my constituents won't just go to South Bend and purchase them?
I don't know.
Will you commit to withdrawing your department's rulemaking attempt to ban certain vaping products and instead work with the legislature on a statutory change that sets up a fair and reasonable marketplace for these adult products?
Our priority is to work with the legislature on working to set something up in statute to help regulate this.
We made great progress last term with Senator, Anick and in a bipartisan coalition. Passed out of the Senate with strong, bipartisan support, but it seemed like with as much, and it went farther than I ever thought I would go on certain legislative intent. But it was stalled because administration just wasn't 100%. I think they were getting about 90% of what they were asking for. And I guess, what's your comments on the legislation that passed out of the Senate last term?
Unfortunately, I was not involved in policy development or discussions over the last couple of years, so I'm not as familiar with what came out of that legislation. But moving forward, I really would like to continue to have those discussions and working with you on developing those.
Senator Anick?
Thank you, Mr. Chairman. I will talk about that for a minute because I do appreciate the work I did with the chairman and others on that legislation. But, sorry, I had a line of questioning I was going to go down. Also, the chairman made a great point for my bill, My Supply, which would work with the private sector to help coordinate, not just in pandemics, but in floods and other things of that nature. I'd hope to get your support on that at some point in time. But I want to get back a little bit to the general intent of what advised in the consent hearing is to talk about the qualifications of the director. Obviously, we've asked a number of questions specifically about the pandemic, but at some point in time, the pandemic will be over, and we need to know a little bit about your background. Could you briefly discuss your academic and your professional responsibilities that I think make you a perfect candidate for this position?
My undergraduate degree is a bachelor's in public administration, and I began working on a master's in public health degree at Tulane University. I completed half of that degree and decided to come back home, and where I was able to start working with the Alzheimer's Association and getting experience in advocacy and policy specific to long-term care. After that, I had the opportunity to work in the House with then State Representative Bruce Caswell, worked on the Department of Community Health budget, and I worked on health policy, transitioned to central staff, being a policy advisor for the caucus, was able to branch out a little bit of that policy into human services, both human services policy and appropriations, as well as health insurance and retirement and pension. We didn't have a lot of staff at that time, so I had a lot to work on, and continued down that policy road, both in the legislature and then externally with a couple of different firms in the interim. In 2013, I was able to go over to the Department of Community Health where I did continue specifically on policy development. That was my role there. And I left in 2016 to go work for Trinity Health in government affairs, where I was exposed more to the administration of health within the health system, a lot of more federal policy, and I also completed my master's in business administration. I returned to state service in 2019 in the position of Chief Deputy of Administration. My background is strongly in health policy, and I've been involved in a lot of the policy development that's been implemented over the last 15 or 16 years in the state of Michigan. But I was really able to take an opportunity, given that I was not central in policy development in the department the last couple of years, to focus on administration and structural functioning with financial operations and budgeting and information technology in those areas, which I've also really enjoyed. So I have a really deep knowledge of all of the elements within the department. I have a perspective of what's occurred over the last few years. I was in the department when we went through the merger, Department of Community Health and Department of Human Services. And I think if many of you know me, know that this is a joy for me to be able to work in this department and work with the people there and work on the programs that we do work on. And so I'm really excited to take this opportunity and continue that work that we're doing internally and continue the work that I know that you are all doing, because I know that we have a shared goal of protecting the health of Michiganders and providing opportunity to individuals in this state. And I think that we can continue to make great progress toward those goals in the next few years.
Thank you. So that is obviously when I met you, when you were in the health policy position, and probably to the chagrin of your now staff or legislative liaison, I would sometimes talk to you and talk to both Emily about health policy issues. No, it was no offense to you. I just wanted to get multiple perspectives, and I appreciate that relationship. And then my last question, I'm not asking you to commit to any policy, but will you commit to working with us both individually if we need it? Because I would like to finish before I'm done to get a framework in place both for folks that are using tobacco, vaping products, folks that are selling it, and obviously folks that advocate on both sides. Will you commit to, if we need it, personally working with us on that?
On that and anything else that you want to work on and have discussions about, absolutely.
Thank you.
It's not midwife licensure. Senator McBroom.
You don't have to bring that up. That issue's over. He's always got to be poking the bear, doesn't he?
We all have a role.
Too soon. Thank you, Mr. Chairman. I have a couple additional questions. One, still back on talking about the pandemic. How do you and the other decision makers in the administration and the department analyze and consider the varied outcomes we see around the nation from states, regardless of what level of regulations they've placed on their population? I mean, it's just all over. I mean, you can look at a state that's been really tough and they've got worse outcomes, or they've got better outcomes. And you look at one that's hardly doing anything, and some of them are better and some of them are worse. We have so much variability. What kind of discussions then does the department have on how do you determine whether it's worth doing this or not worth doing it? Because I mean, there's at this point, a year into it now, we've got data points to look at, or not even data, but at least outcomes to look at.
We are fortunate enough to have partnerships with great universities in schools of public health in the state of Michigan. And we've been able to work closely with the University of Michigan School of Public Health, where they assist us in doing those sort of analysis and comparisons. And we can see what's occurring in other states when they either place restrictions or loosen restrictions, and compare those metrics to the state of Michigan. And we follow those closely. We get an update. I mean, there is an update on that every week from them on what we're seeing. And we continue to try to hope to learn from what other states have done, some of the actions that they've taken, and I think some states continue to learn from some of the things that we've done as well. And the more that we can share our information and the things that we've learned, the better we are going to be able to respond, not just in this pandemic, but if, you know, we face another crisis like this sometime in the future, that we will have those learnings to draw from.
Do you think that there is a particular state or even country that those advisors at U of M or within the department look towards as being the archetype of what we want to accomplish in Michigan?
I haven't seen anybody make that sort of recommendation on who we would want to follow, but I think just from an anecdotal perspective, when I do listen to the news, or I am able to tune in, we've seen Australia be fairly effective in what they've implemented.
Is there somebody that we look at as being the absolute example of who we don't want to follow?
I haven't looked that way. I'm always looking for mitigation, not for spikes. So
I'd like to shift to a couple of questions that aren't necessarily strictly about the epidemic. You know, before it came out, before the epidemic, I was working a lot of mental health issues and care across the Upper Peninsula, where, you know, we really have a shortage of psychiatric care availability. We end up doing a lot of telemedicine. We contract with psychiatrists in Florida for children. It's very, very difficult for us up there, and yet the UP, despite being an enormous landmass, functions almost as if it's one city of 300,000 people. And so you look at a population that way and say, well, how many psychiatrists would be in a community of 300,000? And we don't have that. Mm-hmm. And how many hospitals would you have? And what mental health services in particular would a community of 300,000 have? And we don't have that there. Mm-hmm. So what do you see? I mean, you're familiar with the situation to some extent from your years of service. I mean, what kind of leadership can you bring on this issue and help the people of the UP deal with what's really becoming a really serious crisis for us?
I would really, really like to make some progress on being able to expand access to behavioral health services for the people in the state of Michigan. Every geographic region has its challenges because we have a shortage of access points. And I think we really need to spend a lot of time thinking about what are the best ways to serve people in crisis, both short-term and long-term, in these different regions, and then try to identify where we have those gaps. I would really like to be able to move our focus toward providing smaller community-based services, and those can be outpatient or in the home, or they could be a smaller residential facility that isn't quite an inpatient facility, so that people have a place to go when they're facing a crisis. And even when they're not at the point where they're facing a crisis, where they feel like they need help, and being able to turn to a place to get that help. And it's going to take a lot of creativity, it's going to take a big commitment, and it's probably going to take an investment on behalf of the state in order to expand those access points in Michigan. And I will say, when I say creative, I think we do need to focus on putting together a system that will stay valid and useful for the coming years, and that does mean that we need to incorporate those telemedicine services and you fully leverage our capabilities to do that. Because while we've all become more used to meeting virtually now than we were a year ago, if you have children, I know you have children, I know my children, they are used to interacting with people virtually. That was not strange to them when they transitioned over to a virtual school. So being able to think about how we're providing services to different age groups is going to be really important to expand that access and capacity for people in the state. But I think we have a lot of opportunity to do more, and I think we should.
You think that one of the critical parts of this puzzle that are holding us back is the mental health code that we have in place is based on a delivery of service model that's oftentimes 100 years old?
I think we certainly should look at flexibility in the mental health code, but I think when it comes down to it, we just don't have enough services for the number of people who need services.
And then, you know, it's funny, I mean, if we were having this discussion prior to the epidemic, you know, one of the big things that's been really critical on my mind, it was something I brought up with Director Gordon when he was in this committee, was how it works at the local offices where services are provided to our communities, where people come in and work with an employee of your department to obtain help, whether it's food assistance or Medicaid enrollment, all of those aspects that we provide at those local offices. And the previous administration was part of a very significant consolidation of these offices and of these services. And I was very troubled by the fact that the consolidation of these services to the largest urban areas that we have oftentimes doesn't reflect the fact that people who need the services the most have the least ability to travel to obtain them. And so how do we, COVID has changed all of that in a sense, but when it's over, are we going to be able to go back to the in-person model, or is it gone forever for this provision of services? Have we cracked the nut now and it's no longer a big deal? Or do we still value the relationship that a citizen in need establishes with a caseworker?
I don't think the in-person model will ever go away. I think we at the department level need to remain as accessible as possible to the public and individuals who are looking to apply for services or are receiving services. I do, however, think that we can take a look at what that footprint looks like across the state, and it may look different than what it looks like now with an office full of people, where we can potentially be more mobile but have sites that people can still come to. And we're currently actually working on developing a plan for what we think that would look like statewide as we move forward into the future. And I don't know what the date is for the completion of that, but I will certainly let you know when we're completed and we can have that discussion, because I'm really excited about that.
My experience, years in the House and then short time here, those folks who work in those offices for your department are just some of the best information that we can get for whether a program is working or not. I mean, the frustration that they had with bridges and the implementation of that, and the failure of our departments to consider the fact that a piece of programming software should be consulted with the guys who are actually going to be doing the data input more than consulted with those who are going to be extracting the data. So we could make a program that's actually useful, because we can do anything with extraction, but the input is where the true difficulty lies. And I really hope that the department will push hard on DTMB when it comes to developing software and stuff, to talk to the employees who are doing that data input, because they're your gateway to the citizens and are so important to hear from them.
Part of the reorganization that I mentioned earlier is specific to that exact issue, where we want to bring together all of those areas that are interacting with employees and really focus on the employee experience, and making sure that we are, one, providing them the support and resources they need to do the job, but also getting feedback on what we can do better so that they can do their jobs better. Because you're right, those are individuals across the state are the ones who are making these programs and services accessible, and we need to make sure that we're relying on the information and the expertise that they have to improve.
Thank you, Director. Mr. Chairman, I have to step out for another committee hearing, so
Thank you.
what
Senator
do we do
Bumstead.
further now?
Senator Bumstead.
Thank you, Chairman. The first question might seem kind of silly, but I have to ask it. Can you tell me why high school athletes must wear a mask and while playing sports and college and professionals don't?
The college and professional sports teams are all undergoing a very rigorous testing protocol. The high school sports that are not undergoing the testing protocol, we ask that they remain masked because we know it's an effective mitigation strategy. But we have been talking about and thinking about, with the ability to do more testing, if that's a way that we could balance that out with all competitive sports, if we can get everyone in a simple testing protocol as opposed to being masked. So I think that's something that we should continue to discuss, because there are viable other options.
We've seen workers safely work in grocery stores, hospitals, restaurants, and retail stores. Can you tell me why those who work in offices such as many of the state employees or those in the private sector are still restricted to working from home?
We are going to start working very closely with Leo and with the business community to develop a plan to get people back into the office. And I think for many of us, we're used to what our office environment is. I think we need to be sensitive to the potentially different types of fields that we're talking about, but I think that we are excited to have that discussion and be working with the business community to figure out how to do that and get people back into the office.
You know, when those discussions, are they going on now, or?
I believe they're starting as early as next week. The governor did just announce on Tuesday that she's putting together a formal work group to do this, and we'll be working to support that and move that forward.
Okay, thank you. One real important couple questions here for my district. Michigan Ventures is in my district, and it's a huge attraction for West Michigan, hundreds of thousands of people. Mm-hmm. Currently, water parks are closed under the latest order. Can you tell me what metrics need to be achieved in order for Michigan Ventures to reopen their outdoor water park? Also, they just did a job fair at Michigan Ventures last week, and they're going to be employing 800 this summer if they're open. Mm-hmm.
So again, we continue to look at those case rates, and we're looking at that trend going down. As I mentioned, though, we do have other tools now that we didn't previously that don't just rely on those case rates. And so one of the things that we have started having discussions on and will continue to develop a plan for is how can we potentially utilize that rapid testing, on-the-spot testing, to open up more facilities. And that type of place would be the Michigan's Adventure, which I've been to because I'm from West Michigan too, would be the type of facility that we would want to try that model out on. So I will certainly keep you in the loop, knowing that that's in your district, and we could potentially work with them.
Typically would plan an April opening.
Okay.
And when you have 800, and it's usually older high school kids, college kids, and some of the locals, quite a few of the locals that just are looking for work for 6 or 7 months. So it's a big deal and a huge attraction, mm-hmm. and for all of our recreation on the west side. So, thank you.
Yeah.
A few questions from some senators that aren't on the committee, so I'll try to go through a few of these. I think with the former director, I think we had like another 5 or 6 members of the committee 2 years ago, if I remember that right. So I try to do it in the time of social distancing, try to do it in a little different way. So I'll just go through some of these questions and look forward to answers. There's recently been much news about opening vaccinations up to 50 and over. Well, in Livingston County, there are over 13,000 seniors, 65 and over, waiting in line to get their first shot due to the SVI index distribution. How can you justify this?
So we've been utilizing the social vulnerability index. I think we talked about this a little bit last time on the allocation formula that we use. However, it's important to remember that we don't allocate all of the vaccine that's coming in the state utilizing that formula, where we purposely keep some more flexible. So what we've looked at can we open up for 50 and older with disabilities or underlying conditions, or just 50, we also took a look across the state at the counties who didn't have as many of their citizens 65 and up vaccinated. And so we have also, last week and this week, sent an additional allotment out in addition to the general allotment that those counties get to help them catch up with that 65 and older population.
Then you're not following an SVI index on that distribution model?
Not on that one. We're looking, on that one this week and last week, we were looking at trying to make sure that we were getting as many 65 and up so that they could catch up and be able to open up for this additional population.
How many doses that are going to Livingston? Is there last on the distribution index?
I don't remember. I can get back to you. I have the breakdown of all the counties that were receiving additional doses in my email.
Last week in this committee, you were asked a question that specifically referenced the need for Michigan citizens to know of the constantly changing rules related to the Michigan Department of Health and Human Services orders. You were asked why didn't you hold a press conference or have a press release to inform citizens when you extend the rules to March 29th? And you said, in fact, you had a press conference, which you attended, and there was a press release. You commented that your error was because this was your first order. You hadn't mentioned the expiration date of the extension. In fact, the press conference was entirely focused on schools, more specifically school sports, with a few minutes at the very end encouraging schools to go back to in-person learning. There was no mention of the effect of the changes to businesses, though you did say the orders are online. Is your assertion that you expect all businesses in Michigan to check MDHHS website daily in the event you change the rules on their businesses?
The previous order prior to Tuesdays was a change to the competitive contact sports, and so that's what we covered. I try to be as transparent as possible in those press conferences about what we are adjusting, and I ran through those on Tuesday when the new epidemic order came out. We also try to make sure that we are getting, of course those things are online, but we can't assume or hold people accountable for checking a website daily. So trying to utilize other communication methods to make sure that we're reaching as many people as possible. So that they are aware of what's coming, and that's working with, potentially trade associations, other media outlets, and with all of you to help make sure that things are being communicated as accurately as possible.
That wasn't, but that specific rule on the extension for restaurants, the 25% was not
I understand.
related in either the press release, either the press conference, either material supplied to the legislature. And so I'm saying and it was reported as such when, I guess, when was it, 2 weeks ago, when reporters said 10 days later, oh, this was, by the way, here, when everybody was waiting, I think, till the end of February. They thought there would be a new order for the end of February.
Yeah, I understand what you're saying now. Yes, I heard that feedback, and I tried to be very clear, and will continue to be very clear if and when there are new orders coming out on what the time frame is on those.
Was that purposely left out of the press releases
It
in the
was
press
not.
conference?
No.
So if reporters were to FOIA emails or other things like that, they would not see that anything was made to deny, to make sure that this was not mentioned in the press conferences or in the press release?
No. I try very hard to remember to do some of those things, but I will make mistakes sometimes, so I apologize, but I do appreciate when people are able to say, hey, and then we can learn from that moving forward.
During the time before the Committee on Education and Career Readiness, you committed to Representative Posthumous the trends and data the Michigan Department of Health and Human Services and the administration are using as the basis for past decisions about school sport restrictions and potential future restrictions. A letter was sent February 10th by Chairwoman Theis requesting that information be sent. When do you intend to honor that request?
That I am working on doing just that, and that's what I've been referencing throughout, not just in this committee, but when I'm having conversations with some of your colleagues, working on getting those things together so that we can have a complete discussion about what's occurred over the last year and how it affects what we're doing moving forward.
You don't have a timeline on when this request will be honored?
I don't have it final yet, but as soon as I do, we'll respond to that, and I will let you and all of your colleagues know.
Well, I guess this is the challenge that I think our constituents are having, small business owners are having, is once again is going down to what is the matrix and the positions on what's actually used. And I, again, not having, I guess Indiana's the closest state to me, is that, Indiana does it pretty clearly in terms of, blue, yellow, orange, red, county by county. And this is the restrictions that the county has if you're hitting a certain positivity rate over a 7-day period or weekly cases per 100,000 residents. And those are kind of the leading, the starting indicators are kind of those two. The trailing indicators, of course, are deaths and hospitalizations, as we know. And then you can pretty easily see what those requirements are by the color codes. And you can see where those trend lines are, pretty public, pretty open in terms of what's allowed and what's not, and regionalized. Has there been any discussion or debate on having this kind of regional reporting and easy to read?
Yes, yeah, we've had a lot of discussion on that. We do try to focus again on those regions that were developed early on, and being able to update that model as we move forward, knowing that we are looking at, again, those declining trends, which is very heartening for me, and that we have other tools in hand to help us outside of just those traditional mitigation models to continue to re-engage different sectors more fully.
When asked last week that the type of legislative input was provided on then recent MDHHS order, you spoke exclusively to input regarding high school athletics. Why does it appear the administration did not want public or business owners or associations or stakeholders or the legislature provide input or even know about the extension limitations related to bars and restaurants?
I don't know if that was true prior to my coming into this role, but I've had extensive discussions with stakeholders and some legislators on what we're looking at and some of the decisions that we've made.
Did you talk to any stakeholders on the extension before you did the extension with the sport orders?
I had spoken to the Restaurant Association often, and we are currently continuing to work with some of the venues that felt they should have been addressed in that order, and so I have discussions coming up with those venues so that we can learn more as we continue to work toward getting through this pandemic.
What science and data were you relying on that extension? What were you looking at specifically?
On the extension or the changes?
The extension that you had, was 3 weeks ago, I guess now.
Oh, again, the extension was for the school sports, the school athletics, so that we could.
Along with the restaurants, another month at the 25% with restaurants.
Well, because we did the amendment with the athletics, we extended that, the length of time, the expiration of the order, so that those school teams could put in place their seasons.
So, but along with that was that the restaurant restrictions were also extended.
They were, yes.
And so what was the science and data used for that extension by a month of those restrictions on restaurants?
Those restrictions were in place. We didn't make any changes to those restrictions. We
So
only,
you weren't following certain matrices of data that was coming in on hospitalization rates or on COVID positivity rates or on cases per 100,000? You weren't following any of that data and saying, this is why we're extending them out a month, even though they'd been falling for quite a while?
so the original restaurant restriction, the opening up to the 25% had happened, I don't remember the exact date when that occurred.
Well, it
The
started February 1st.
22nd. Yes, and it
that
started
was-
February 1st.
Yeah, it was
And then-
announced, I think it was announced, what was it, January 23rd or so, if I remember correctly, or 20, yeah, I think 23rd.
Right.
And then, so it was announced a little over, 10 days before the enactment. And so anyway, that's-
So it went into effect February 1st, and it had been in effect for a couple of weeks. In general, when we talk about loosening restrictions, what we know that we will see most likely is going to be an increase in case rates. And so we wait a few weeks, 3 weeks really, so that we can get 2 full weeks worth of data to see what was occurring. So my focus on that order was the amendment to the school athletics, to the competitive sports. And we extended the length of the order so that the school athletics were able to plan their seasons, knowing that we will continue every day to look at the trends and what we're looking at and what is in each of those orders, and that though they may change prior to the expiration of that order.
we still don't know what specifically you're looking at in terms of what those trends are. Is it
Yeah.
positivity rates? Is it cases per 100,000? Is it hospitalizations? Is it death?
Yeah. I want to, I wish I had some things to show you while I was here. What we're looking at, what I'm putting together is something that, to explain all of those things in one place. So I know it's easy for me to run through them verbally with you, and we can talk about, we look at the case rates, we look at the trends of the case rates, we look at the positivity rate because it gives us a good idea of if we are getting enough of a sample and we're doing enough testing, and we can see the trend with that. How those then affect the hospitalization rates, because we know when we see our case rates start going up, we're going to see a lag in data of our hospitalizations, which will then increase, and then we'll see a lag in the data of the death reporting, which will follow those case rates increasing. So we watch all of those together, knowing that the case rate increase is going to be something that could spur the increases in the other one. And then we look at those other individual factors like the hospitalization capacity, the ICU capacity, how much PPE that we have available, and what our health provider resources look like at the time, and all of those go together. So as I'm looking at these, and this is what we saw a 6-week decrease in case rates, continued decrease, and pretty significant, taking us back to where we were in October as far as our case rates across the state. So we want to continue to loosen those restrictions in such a way that we continue to see a decreasing trend, but we're not doing so quickly that we're going to see a big spike that's going to cause a large outbreak.
Did we see an increase from the reopening of restaurants?
We have over the last week seen an increase in some regions, yeah.
So a month later, after reopening them at 25%, we saw something a month later. Is that related to restaurants, or is that related to something else?
Well, we loosened restrictions on restaurants, gatherings, and then we started the competitive sports. So I think we want to make sure that we're identifying as much as we can where those outbreaks are coming from, so that we can ensure that we're tracking those appropriately.
Senator Rumstead?
Thank you. Just to kind of go into that, when you're looking at the restaurants, is it in one area, statewide or regional, or where you're getting that new data from?
We've seen a plateau across the state in general. We're seeing increasing rates in the Saginaw region and Grand Traverse.
These are some further questions from some of my Senate colleagues. On February 3rd, you testified in the Senate Appropriations Committee. When asked specifically about the Social Vulnerability Index, you stated that because the vaccine is not available to the general public, the younger people would not be able to get vaccinated ahead of those in higher priority group unless they were an essential healthcare worker. Do you still stand by that statement today?
Can you repeat just the statement?
This was a direct quote from one of the questions in committee about a healthy young person with a high social vulnerability index. The quote was, "Well, I just want to clarify that the vaccine is not available to the general public at this point. So unless it would be a 20-year-old who is one of those essential workers, they would not be included in the queue to get the vaccine at all."
That's right, they should not be.
You still stand by that statement?
According to the priority guidance that we have given to those vaccine administrators, yes.
Do you deny that Detroit is now vaccinating those in lower priority groups before other people in higher priority groups and other communities have all been offered the vaccine?
Again, we provide the guidance of the priority groups that we expect to be vaccinated, and we rely on those organizations or providers who are doing the vaccinating to implement that guidance.
So this is why Detroit's so much further ahead than Livingston, is because of where MDHHS is prioritizing those vaccines then?
Detroit is also behind on vaccinating individuals 65 and up and residents of this city as well. So we continue to look at those counties and districts to identify if we're hitting is not a great word, if we are reaching the populations that we are working to vaccinate in our priority groups right now.
If race is a risk factor for COVID susceptibility, why isn't race a priority group factor?
I'm sorry,
If
say the end
race
of that.
is a risk factor for COVID susceptibility, why isn't race a priority group factor?
Race is incorporated in the social vulnerability index. So race is not the only risk factor, as we know, when it comes to COVID transmission. It also has to do with age, and it has to do with people who have underlying conditions and the living situations that people may be in, like a congregate care setting, like a nursing home. So the priority settings are around those groups, the risk factors of the location that they may be in, and the social vulnerability index points us geographically to the directions in the state where we may have higher populations of people who are at higher risk.
Another question, can you assure the committee that you would not accept any severance package from the administration or any other employment status that would require a confidentiality agreement?
I can.
What?
I can.
Okay. Senator Amnick?
Thank you, Mr. Chairman. And the Chairman brought up a question from one of our colleagues. I want to take a little bit different turn, but I actually think it's an important question. I obviously represent a community with a large African-American population, and from the polling I've seen, and obviously it's not all across the board, but African-Americans, I believe African-American men in particular, have a hesitancy to take the vaccine. What are we doing, or what should we be doing? Because I know what we're doing at the local level, and hopefully it's going to work, but have we seen nationwide or parts of Michigan or other places that has worked well to help? Because I understand why they have the hesitancy, but is there something we can do to better reassure that particular population about the importance of taking the vaccine?
Mm-hmm. We are working with the Protect Michigan Commission right now, which is a broad group of individual stakeholders from various elements of the economy in the state, both human services, health, and private sector. And one of the focus points of that group is education and communication on the safety of the vaccine. We've seen a couple examples of other things that have been done locally, and I'd love to see what Genesee County has as well, that seem to have been successful in reaching different target groups on the safety and efficacy of the vaccines. But we do need to continue to do more and work as much as we can to ensure that we are communicating that these vaccines are safe, that they work, and that people should be getting the vaccine when it is their turn.
Lastly, now that Johnson & Johnson has had their vaccine approved, and I believe the President used the Defense Production Act to help coordinate between Merck and Johnson. Johnson, what do you expect that our, and this is a tough question, so I'm not expecting you to be able to answer it exactly, but how many vaccines we'll be getting in the short term, midterm, and how long, if the rates continue to improve, how long before we can get the adult population, 16 and over, vaccinated? I don't expect you to give me a date, but just approximately.
What I can tell you in the short term, we did get the allocation of Johnson & Johnson this week. We were notified yesterday that we would not receive any more Johnson & Johnson vaccine for the next 2 weeks, which was disappointing. But we should start seeing the allocation again in 3 weeks. And then we do see our allocations for Pfizer and Moderna increasing. But we anticipate over the course of the next month, I would say, that we'll start seeing a significant increase in the quantity coming into the state. I couldn't guess when we will complete the vaccinations of the adult population in Michigan, but I can tell you I would love for it to be as soon as possible because I can't wait to get my vaccine, and I am in the lowest priority group, and I'm really ready. I'm really ready. So anything that we can do to continue supporting that, we'll be working on, and hopefully you'll be supporting us in that as well.
Senator Bumstead.
Thank you, Mr. Chair. Coming up shortly, I have a district, we have a lot of migrant workers, a lot of fields. We have to start off with asparagus, literally thousands. What do you think is going to be the uptick with, with this new open borders policy at the Mexican border? Do you think that's going to affect Michigan?
I have no idea, but I do know that I think in your district is the asparagus capital of the world. Is that right? In Shelby? That's what I thought.
Yeah, it's a big deal for my area, processing as well.
Yes.
And I know MDHHS has put a lot of restrictions in place with housing, and a lot of it's just unattainable. So it's going to be tough for my growers and my processors, and it's something we really need to look at because it's going to be a problem.
We do have we were able to put in place a really effective testing program with the agricultural workers. And we are working on putting together a protocol and a strategy for vaccinations of agricultural workers, food processing, and in the farms as well in the spring, because we know that that is a population also at risk and very mobile, interacting with many other people.
Are you familiar with Senate Bill 1?
No.
What?
No.
It's the legislation would require legislative approval of your epidemic orders after 28 days. Passed out of the Senate this last week. Last week we asked whether you thought you should be able to issue epidemic orders unilaterally without the consent of the legislature, and you said it is, quote, absolutely the responsibility of the state health department to take action and have that authority, end quote. So it is safe to say you oppose Senate Bill 1?
I don't know what Senate Bill 1 is exactly, but I think that changes to statute and policy are the purview of the legislature and the governor, and my role is to implement that.
So then you'd be open for legislative approval past 28 days of your epidemic orders?
That is for discussion and deliberation in the legislature and with the governor, and my role, again, would be to implement whatever that is.
Any possibility that you ever be open to additional limits on your authority to issue epidemic orders?
I think that that's a discussion that is in the purview and the responsibility of the legislature and with the governor, and that my role is to carry out and implement the public health
Deals
code.
with your department, and as director of the department, my guess is the governor is going to ask you for your opinion. What would be your opinion to the governor?
I haven't seen anything like that, so I don't have an opinion at this point, but I do think that that is the responsibility of the legislature to pass any changes to the public health code or the authority of the department.
Your authority should last for years or forever?
I think that my job is to carry out and implement the law, whatever that is.
Are you willing to work with the legislature to determine what a reasonable limit on your authority might look like?
I am always open to having discussions with the legislature and others on ways to improve and partner to move forward.
Would you have any specific recommendations now in terms of what kind of limitations you would accept or reasonable authority changes that you might be willing to look at or work with us on?
I don't have any right now.
Last week, your department issued notice to licensed tobacco retailers that exceptions to the mask mandate only apply for the consumption of food and beverage. Is that correct?
Yes.
Specifically, businesses whose licensure exempts them from Michigan's smoke-free indoor air law
Yes.
received notice that the February 4th, quote, gatherings and face mask order, while accommodating mask removal for food and beverage service, does not apply to consumers wishing to patronize Michigan cigar lounges. Can you explain the scientific data behind the department's distinction between COVID transmission when it comes to dining in comparison to smoking when social distancing and mask wearing while not smoking is observed?
So we know that high-risk environments are enclosed spaces with a lot of people when they don't have their masks on, right? So that includes restaurants and taking your mask off to eat and drink. In a cigar bar or a hookah lounge, you have people who are actively exhaling aerosolized particles into the air. So again, that's a high-risk environment. However, I have had the opportunity over the last couple of days to talk to a couple of people on this issue. And I have some time Monday and I think Tuesday with a couple of different groups to learn more about the ventilation systems in those industries, what those look like, and what some of the mitigation measures that they might be able to put into place are. And so I'm working closely with the stakeholders, and I know there are a couple of interested legislators as well, so that we can work to come to a resolution that works for those institutions or those venues, but also work to protect the public health of people who are going there.
Cigar bars in Michigan are licensed. I appreciate that. That's good to hear you're sitting down and doing some outreach. Cigar bars in Michigan are licensed to sell food and beverage while being exempt from the state's indoor smoking ban. Under the department's interpretation and enforcement of the mask order, it is generally understood that patrons may eat and drink at these establishments, but smoking is forbidden, even though that's what they are, cigar lounges. Can you explain why the department has made the distinction and how cigar lounges are unique in their propensity to transmit COVID-19?
Yeah, so as I mentioned, taking off a mask and then actively exhaling aerosolized particles into the air. But again, I'm looking forward to having those discussions about how we might be able to come to some resolution for those venues.
The state might be exposed to lawsuits for enforcing restrictions on licensees that are inconsistent with the statutory provisions of their licensure.
I couldn't comment on that.
The March 2nd gathering and face mask orders has eased capacity restrictions for bars, restaurants, and venues to reflect improvement in containing the spread of COVID-19. Could you explain why you feel it's important to limit smoking in cigar lounges while recent actions by Michigan Department of Health and Human Services allow most businesses to enhance revenue in order to recover from the financial difficulties of last year?
I don't think I understood the second part of that
So you're
question.
allowing loosening restrictions here, you're tightening restrictions here.
Certainly not trying to tighten restrictions at this point. We are, again, I'm very optimistic about the trends that we are seeing. I'm very optimistic about how seriously the citizens of Michigan continue to take COVID and the risk to COVID, and it is absolutely 100% attributable. Those trends and those actions are absolutely 100% attributable to the mitigation measures that people are implementing in their everyday lives. As we work to continue to loosen those regulations, I want to continue having conversations so that I can learn more about these different venues to ensure, again, that we can loosen restrictions and allow people to re-engage in some of the activities that they love and they miss, but also work to ensure that we are protecting the public health of the citizens of Michigan and continue to work to save lives.
I guess that's the question is if they have to apply with the capacity restrictions, that's one thing. That's tackling what you're saying, close, confined spaces. They probably have pretty good ventilation systems for, people going to these places. Whereas these other folks, you're restricting on their core use of business. And so I appreciate your outreach, and hopefully we can see an improvement on that. Senator Bumstead? Thank
you, Mr. Chair. That kind of gets back to my whole local control thing. Like I said, I've always been a firm believer in that. But, if you have businesses, the cigar bars that have been doing it right, that have the ventilation, that are doing this distancing and whatnot, and the restaurants doing that, and bars doing the right thing, I just think it's easier for the folks to do it regionally or county-wide or district health-wide than it is at the state level, because there are a lot of people that are really doing it right and they want to get open, and we understand that. But that's just probably just a difference of opinion. I just think it needs to be a local issue.
I don't think there's a difference of opinion there. I think that the state health department and the local health departments work really closely together. And I do think we need to continue to support and invest in our local health departments so that they have the infrastructure and the resources that they need to be able to do a lot of these things locally as well.
I was talking to a ER doctor yesterday, drive home, and he's had a family member or a father in a nursing home for the last year, has been able to visit even, and his dad's vaccinated, he's vaccinated. My understanding is the orders still say you can't visit folks in long-term care facilities, right?
No.
It's changed now.
Yeah.
So it's up to each of these?
No. Visitation is allowed in all nursing homes, regardless of county, and subject to some CMS requirements.
What do you consider visitation?
Going inside to see somebody.
What?
Going inside to visit with somebody.
So that's allowed? And
it is allowed, and what we're asking for visitors to do is to take a rapid test prior to entry into a facility with an antigen test.
So all long-term care facilities are allowed to have
indoor visitation.
Indoor visitation.
Mm-hmm.
And is that happening then?
Yeah, that was effective Tuesday when the order was signed.
Okay. And then, and so that's the requirement that both the folks inside and the folks outside have the rapid test, or is it just the visitor has the rapid test?
There's already a testing protocol in place for nursing home residents and staff. So this would ask that the visitors who are entering the nursing home have the rapid test prior to entry.
Appreciate that. Going back, incredible times to live in, having a vaccine ready, 2 vaccines, now 3, within just months of the start of the pandemic, or within a year. The quickest time before was, 4 or 5 years to be able to develop a vaccine. I guess as you look at December and January, where could have MDHHS in the state of Michigan improve the distribution of vaccinations? We were really low on the list of being able to put shots in people's arms, especially in priority groups. Can you walk me through what went wrong and how things should have improved?
December and January were the priority group, the 1A, which was healthcare workers. And I think that what we learned from that is, from the beginning of the vaccine process, is that we need to work closely with those providers who are doing the administration and have regular communication that occurs frequently, so that we can continue to provide support and resources to ensure they're able to utilize the vaccines quickly and reach the populations very quickly.
This is one of the things that I saw early on. Was there, I heard from some of my local, they were completely shut out of the process, and it was just the local health departments that were there, and there was actually, whether or not they had the equipment or whether or not they had the manpower to set up to distribute these vaccines, was there a prohibition in the rules that said they couldn't transfer those vaccines to another entity?
No, not at all. And we have, in fact, a process for people to transfer vaccines to another entity, as long as they are a MICR. MICR is the Michigan Care Improvement Registry. That's our immunization registry, registered provider and registered in the federal system to be a COVID vaccine administrator.
Because I was hearing from some of my local pharmacists that they were going to some of the local health departments saying, hey, you know, we're used to doing the flu vaccine at our local retirement communities or nursing homes. And they were told that MDHHS had a rule that said they couldn't transfer those doses to a pharmacy. Apparently that changed the second Thursday in January, but you don't know anything about whether there, you said, or whatever you
As far as I know, there wasn't, because I know that we have worked with some facilities to be able to move vaccine allocations either between facilities internal to a system or to external facilities.
How do you feel we are now in comparison to other states in terms of our vaccinations?
We're doing very well in terms of other states, in terms of our vaccinations. We have fallen a little bit in the rankings, which we knew we were going to do when we had to put sort of a pause on first doses so that we could catch up on second doses. But I think we continue to move along fairly well.
Senator Broom, did you have any final questions right now?
I had something, Mr. Chairman, but in all my moving around and between testifying on another bill, I think I've let it slip my mind.
Okay.
My apologies.
That's fine. That's first, but I do thank you for testifying today. The Department of Health and Human Services clearly plays a large role in the lives of the people of Michigan, more than we ever expected, especially after the Supreme Court declared Governor Whitmer's orders unconstitutional. We will likely need another hearing at some point. There are more questions. I could go on for pages more of questions that I have, but we'll likely need another hearing as there are more questions and thought required regarding this appointment. We do need to have a decision: is this Whitmer Hertel era at DHHS? How different will that be from the Whitmer Gordon era? After 2 hearings, I think there's continue to be some legitimate questions on how that and if that changes. And I'm looking forward to really seeing an end to these unilateral, seamlessly endless and ever-changing orders, and trying to provide a real matrix and guidance on what the citizens of Michigan, what our seniors, what our small business owners can expect out of this department. So I appreciate your time. I know in the seat for 2.25 hours is quite a long time. But it is something where it's such a critical department in so many people's lives as people try to get back to work, back to business, seeing their kids educated, and we're going to continue to have some questions. But thank you for your testimony today, and not seeing any further. Oh, wait a second. I do think we have a bunch of cards and some other things for the record. So, Mr. Clerk.
John Van Fossen with Meyer supports the nomination. Melissa Seifert with ARP of Michigan supports the the appointment. Brett Jackson with Economic Alliance for Michigan supports the appointment. Carolyn Wilson with Beaumont Health supports the appointment. Matt Black with Michigan Academy of Family Physicians supports the appointment. Alicia Cottrell with Ascension, Michigan supports the appointment. Brian Cepeda with the Michigan Pharmacists Association supports the appointment. Mark Corriveau with Henry Ford Health System supports the appointment. Kevin McKinney with Michigan Osteopathic Association supports the appointment. Melissa Holmquist with the Upper Peninsula Health Plan supports the appointment. John McNamara and Justin Winslow with the Michigan Restaurant and Lodging Association support the appointment. Praveen Thadani with Priority Health supports the appointment. Dawn Siggett with Meridian Health Plan supports the appointment. Hassan Abdallah with Health Alliance Plan supports the appointment. Josiah Kissling with Michigan State Medical County supports the appointment. Tina Decker with Spectrum Health supports the appointment. Adam Carlson with the Health and Hospital Association supports the appointment. Mark Cook with United Health Group supports the appointment. Christine Shearer and Dominic supports the appointment. Sean Geely and Autumn Gillard with Trinity Health support the appointment. Gabe Schneider with Munson Healthcare supports the appointment. Rick Lance with Delta Dental supports the appointment. Lori Johnston with Paramount Care supports the appointment. Jim Kavanaugh with Molina Healthcare supports the appointment. Allison Matazesco with McLaren Healthcare supports the appointment. Catherine Schmidt with the Eaton County Republican Women's Alliance opposes the appointment. Janice Daniels with the Election Integrity Fund and Michigan Conservative Union opposes the appointment. And residents, including Christine Parker, oppose the appointment. And the rest are legislators, including Senator Lasada opposing the appointment, Senator Lana Tice opposing the appointment, Senator Tom Barrett opposing the appointment, Senator Ruth Johnson opposing the appointment. The following representatives also oppose the appointment. John Riley, Bob Bazat, David Martin,